So welcome everybody. This is the webinar series of the Prenatal-to-Three Capacity Building Hub. The title of the series is Moving Away from Family Separation, Cross-System Strategies to Support Young Children and Families at Risk of Child Welfare Involvement. This is the sixth and final webinar in this series. It is on the plan of safe care and how plan of safe care can help states make safety policy a strategy for child and family well-being. I am your moderator, Cynthia Tate. I'm with Build, and we are very happy that you have joined us. We have language interpretation for you, and so I'm going to turn it over to Diego to explain to everybody how this works. Diego?
Thank you, Cynthia. Hi, everyone. Good afternoon or good morning. I'm Diego Ponce. Real quick, I'll give the instructions in both languages. Voy a dar instrucciones en ambos idiomas. So I'm here with the CLC. The interpretation is going to get started after I give these instructions. At that moment, when the interpretation is activated, you will see a globe icon that says interpretation that's going to appear there in the bottom right-hand corner of your computer screen. You will select that globe icon and you will choose your preferred language. That's if you're joining the meeting on a computer. If you're joining the meeting on a cell phone or tablet, you'll be looking for the More button or the three dots button that's going to appear there in one of the corners of your computer screen. You will select those options, and that's what's going to let you find the interpretation globe icon, which allows you to select your preferred language in one of those two devices. So if you're not fully bilingual, I encourage you to select your preferred language just in case anyone were to speak in Spanish and you would like to know what they are saying. If you're bilingual, just feel free to listen to everyone in the original language. And as always, just please pay attention to the speed in which you're speaking. Just primarily focus on not picking up your reading speed. If you have any questions, you can let us know through the chat. Thank you so much. Buenas tardes a todos y a todas. Yo soy Diego Pons. Estoy aquí con el CLC. En un momento se va a activar la interpretación. Cuando se active la interpretación, usted va a poder ver un icono globo en la Tierra que va a decir interpretación ahí abajo en la derecha de su pantalla. Usted va a seleccionar ese icono globo en la Tierra y va a elegir su idioma preferido. Si hoy está asistiendo a la reunión, disculpen, en su celular o en su tableta, busque por favor la opción que dice More, M-O-R-E, que quiere decir más en inglés, o un botón de 3 puntos ahí en la esquina de su pantalla, lo cual le va a permitir a usted le permitirá elegir su idioma preferido de esta otra manera. Si usted no es completamente bilingüe, yo le voy a aconsejar que elija su idioma preferido para que pueda utilizar la interpretación cuando alguien esté hablando en el otro idioma. Si usted sí es bilingüe, siéntase libre de escuchar a todos hoy en su idioma original. Y si tiene alguna pregunta, déjenos saber por el chat. Muchas gracias.
Okay, thank you, Diego. Okay, before I get into the objectives of the webinar, let me just say a couple of things about the chat. Go ahead and enter your name and where you're from into the chat so that folks will know who's here. You might see some friends. This has happened more than once where people see friends and interact on the chat. We will be monitoring the chat as well and try to respond to your questions. Someone has asked if we will have previous webinar recordings available, and yes, they'll all be available on our website for the Build Initiative. If you are registered for any of the previous or this webinar, you will receive the recording, the slide deck, and any associated resources. Okay, so the objectives of this series have been to raise awareness about young children and their families who are involved with or at risk of involvement in the child welfare system, to educate participants about the racial disparities in family separation from child welfare involvement, to promote opportunities and upstream strategies for prevention. And that's the particular focus, by the way, for today. And provide examples of cross-systems collaboration on behalf of our youngest children. So for today's webinar, our objectives are to have an overview of plans of safe care across the country, to learn about Colorado's Plan of Safe Care pilot, and to learn about how Washington is bridging child welfare and early childhood through Help Me Grow Washington. And here are our speakers. You can see their pictures and their full names and titles. I'm just going to mention their first names so you can read the rest. We welcome Aaron. Thank you, Aaron, from Washington State. Maria, also from Washington. And Kate, also from Washington State. And we welcome Alicia from Colorado and Kelly, also from Colorado. So thanks to all of you ladies for your time and sharing your knowledge and your experiences with us. We're excited to hear you today. Okay. So, audience, who are you? Who is represented here? We have more than 500 registrants. You represent 48 states and the District of Columbia. You are from all kinds of different state agencies, children, youth, and families, human services, public instruction, early care and learning, labor, Head Start. You are with city and county governments. You are with colleges and universities. You are with center and home-based childcare. You are with community-based regional, national, and tribal organizations. You're with CCR&Rs, children's museums, and foundations and philanthropy. All right, that is a great spread. Now we have this little word cloud for you because there are too many titles to share any other way, but you can just get a sense from looking at our lovely word cloud here, how many different kinds of positions people are in who have joined us today. We have project directors, early childhood education advisors, we have an attorney, we have program manager, child care collab specialists, family resource coordinators, CQI people, statewide central intake and referral managers, senior policy analysts, et cetera, et cetera. Lots of different folks from lots of different perspectives. And Jonathan says the gang's all here. Absolutely. Wonderful to have you. Thank you so much for being here with us. Okay, so how can you participate? Well, as I said, introduce yourself in the chat, which people are doing, which is really great. If you have any questions for the panelists, you can put them in the chat or you can put them in the Q&A. And we will attempt to address them all, either responding to you in the chat or the Q&A, but most likely in our panel discussion and the Q&A section of our agenda today. And then we want you at the end to complete this survey. We at Build take it very seriously, our responsibility to be attentive to what our participants in our webinars have to say. And we want to know what you have to say, and we use the input that we get to plan other activities, further additional webinars or other kinds of activities. So we do listen. So please take, it won't take long, it's very quick. Just please take a minute at the end, it'll pop up, the survey. Okay. All righty, so we're gonna get started with Aaron. And Aaron, you're on.
Fantastic. Thank you so much, Dr. Tate, for inviting me to be here today. Hello, everybody. My name is Erin Havig, and I'm a state innovation specialist on the Safe Babies team at 0 to 3. And as we were thinking about this opportunity today, we wanted to look at plans of safe care and what is that. So we wanted to give you a quick high-level overview of what does it mean to have plans of safe care, what is the legislation, and how does this all come together. So if you could advance to the next slide. A lot of you who are here, I see people who have titles that are Plan of Safe Care Coordinator, know a lot about this, but we wanted to have some baseline information for everybody. So in the chat, I'm putting a link to a document from the Children's Bureau that just provides a high-level overview in case people want more information. But in order to receive Child Abuse Prevention and Treatment Act funds, also known as CAPTA funds, states had a requirement to have policies and procedures around identifying the needs of infants born affected to substance use or withdrawal. So this change in the CAPTA law happened in 2016. And what's really exciting to me as somebody who gets to see things across a national level is that it's the same law, but it gets implemented in so many different ways. And there's so many right ways to do things. So at the very basic foundational level, this is a literal plan. It's usually developed at the hospital or birthing center, sometimes by Child Protective Services. And each state does it a little bit different. And within that, there's a notification requirement. So right now, about 42 states and the District of Columbia require a CPS notification when an infant shows prenatal exposure to substances at birth. So if we can move to the next slide. One of the things, like I mentioned, I really like the policy pieces of this, of being able to look, what do we have in place and how do we maximize the opportunities when we have a new piece of legislation? So thinking about what our focus on well-being, not just safety. So often when we have a law, we focus on the safety parameters, and we tried to pull together some really excellent examples of states that are focusing on not just safety, they're addressing the safety needs, but looking at the well-being issues as well. There's states around the country that are exploring options of what does it mean to report in different ways. So one of those examples is Connecticut has like a reporting mechanism where they're not telling the name of the person to CPS, but how many births they created plans of safe care for. And then what are those opportunities for expansion into pediatrician and medical home opportunities? We see some unique things that are happening in different states. So we really wanted just to lay the groundwork of this is what a plan of safe care is. It's part of a requirement, and it's been maximized in so many different right ways. So with that, I'll pass it on to the next person.
Okay, Erin, thank you very much. We appreciate that overview. And now we're bringing you the team from Washington, Kate and Maria.
Thank you, Cynthia. Hello and good morning or afternoon, depending on the time zone that we are all joining together from. On behalf of Help Me Grow Washington and Washington State Department of Children, Youth, and Families, I want to welcome you today. Kate and I will be walking you through how Washington State has built a private-public partnership to implement a community pathway through Plan of Safe Care. Next slide, please. So I'll start by just defining a plan of safe care here in Washington as a family-centered prevention plan designed to promote the safety and well-being of infants with prenatal substance exposure and their birthing parents. So as a result of Comprehensive Addiction and Recovery Act legislation changes in recent years, the population of infants requiring a plan of safe care has expanded beyond infants exposed to illegal substances. It now includes infants exposed to any controlled substance. While a family who falls within this new eligibility may not warrant a referral to Child Protective Services, it is important that they have the support necessary to mitigate risk as they bring their baby home and keep their family together and thriving. So Washington recently created a public health response for infants and families when the plan of safe care is developed outside of the child welfare system. In this model, infants with specific substance exposure and no safety concerns are referred to Help Me Grow Washington. So this community-based pathway supports families who are typically screened out and not provided any further services or referrals, and offers continued voluntary support to these families without increasing calls to Child Welfare's hotline. So implementation up to this point has centered on collaboration with hospitals, community partners, and families with lived experience. In addition to training about 94% of the birthing hospitals here in Washington around the new policy and processes, we're working very closely with our state hospital association to support hospital policy development, as well as alignment and parallel implementations such as Eat, Sleep, Console. The other thing I'll mention is that we have worked to strengthen collaboration between child welfare and birthing hospitals, and also intentionally aligned our updated mandated reporter training with the plan of safe care process and philosophy. And lastly, we have also held listening sessions with both providers and lived experts as we continue to iterate upon our work. Next slide. So this diagram illustrates the Plan of Safe Care portal's high-level process flow. Once a healthcare provider at a birthing hospital identifies an infant as substance exposed, they access the portal, which is essentially a secure web form. The provider first inputs de-identified data on the substance exposed infant, which automatically gets sent to DCYF. The algorithm then asks the provider questions about safety and other child welfare intervention criteria that helps the provider essentially determine whether a report to child welfare is required or if a notification to Help Me Grow Washington can be made. If the infant requires a report to child welfare, the provider is instructed to call DCYF, our intake line. And if a report is not required, the healthcare provider then completes a plan of safe care. And with proper consent in place, the plan of safe care gets automatically sent to Help Me Grow Washington along with the family's contact information. Help Me Grow will then reach out to the family to begin the care coordination and offer voluntary supports and services. Next slide, please. Okay, so here's a list of some of the common types of prenatal substance exposure that, when paired with an absence of safety concerns, are referred to the community-based pathway. I will say that prior to this implementation, all of these circumstances would have been called and screened into CPS for an investigation here in Washington, and now are being offered voluntary supports. Next slide. So what Washington State has seen through the Plan of Safe Care work is that essential services such as food, concrete support, family stability, adult and pediatric medical care, child development support has been really pivotal in this community-based pathway. We are slowly seeing referrals increase and are now doing work to iterate and refine the warm handoffs and intake screening process with our own DCYF staff. Next slide. I also wanted to touch just briefly on funding, as we have found that it's been incredibly helpful to fully braid funding for sustainability. So we use federal CAPTA dollars, general fund state dollars here in Washington, as well as private philanthropy dollars. We have also had the Department of Health in Washington support some small aspects of this work. And I'll say that this braiding of funding has really allowed us to adapt and maintain resources when one funding stream is limited. Okay, from here, I'll pass it off to my partner, Kate, who will talk through a little bit more detail about our public-private partnerships.
Thank you, Maria. All right, next slide, please. So I'm going to talk a little bit about some of our ingredients for success, and definitely still learning, but kind of some things that are working so far. Next slide, please. So one example of a success in this work has been our public-private partnership between the Department of Children, Youth, and Families, where Maria works, and Help Me Grow Washington, where I work. And our approach to this public-private partnership demonstrates moving from a contractual to more of a collaborative relationship, and this mindset shift from compliance-driven approach to an outcomes-focused approach, where a government agency now works alongside their collaborative partners to define and measure progress towards our shared goals. And sustaining partnerships with government can help collectives reach better outcomes for everyone, but also needs to be recognized as an ongoing process, requiring commitment, patience, continuous learning, and a willingness to adapt as we learn. and guided by a common vision of reducing the number of infants and young children placed in out-of-home care by ensuring their safety and well-being, it is important that we meet families where they're at and connect them to services and supports that they want and need. And both are significant in promoting positive outcomes for families. Sharing a commitment to placing families and children at the heart of this model, we worked together to update the child welfare intake screening policy, developed clear shared language, and used a collaborative co-design process. The department worked alongside other state agencies, as Maria mentioned, and community partners to design and test this family-centered, community-based support and safety pathway for infants with substance exposure. This referral pathway is offered, the community-based referral pathway, rather, is offered through Help Me Grow Washington and is a community-based response to wraparound supports and services for families that otherwise would have been traditionally routed to CPS or offered no additional resources. And this public-private partnership leverages the assets of both DCYF, or strategy, policy, and financing, and then Help Me Grow Washington with systems building and implementation. Using an online portal in the pathway logic and screening protocols, which was co-designed by providers, tribal partners, and state agencies, families now meeting the agreed upon and established criteria can either receive a plan of safe care from the community through Help Me Grow or from Child Welfare Department, again, if CPS case is warranted. Next slide, please. So we've had a lot of key partners in this work, which has been really key. And some of the partners that were incorporated into the design of this model, given their existing work with families and their unique strengths, are listed here. Some of these include urban Indian organizations, a medical legal partnership, parent ally mentors, home visitation models like PCAP or Parent-Child Assistance Program, nurse-family partnerships, and the 211 system. And then state agencies like Maria mentioned, and divisions of the department, including IDEA Part C and Early Supports for Infants and Toddlers, or ESIT. Next slide, please. Another unique aspect of this model is that we really celebrate and center communities' existing strengths. So some of the ways that we do this is by bringing together existing community collaborations, not trying to reinvent the wheel, identifying aligned work in each community, and providing tailored support depending on the needs. There's no one size fits all in this approach. And additionally, we continue to hold listening sessions and one-on-one conversations with parents with lived experience to gather essential input and their feedback on our processes, outreach, and follow-up, and our outreach materials as well. As you can see, this is a flyer we recently redesigned with families with lived experience. All right, some challenges, considerations, and next steps we're considering. So this work is not without challenges, and some of these challenges, or we think of them sometimes more as opportunities, that we're overcoming are around our virtual engagement model. So our Help Me Grow model is virtual versus in person. So this does require strong engagement techniques to reach out to clients and these families to establish trust and rapport. And then we do connect them to longer term in-person supports. We've had to be really creative with that. And then realizing there's this need for more flexible funding for concrete goods, especially things like housing, baby supplies, and transportation. As concrete goods and supports are vital for this population, we're working continually towards identifying sustainable funding for flexible fund that can assist with these types of things. And then trust. Families referred through these community pathways may be initially distrusting of Help Me Grow, as they could see it as being an arm of child welfare, and they might have hesitation to answer the phone or follow up with us. So it's important to be transparent about the relationship that we do have with the child welfare and DCYF, and be really, transparent about the data that we do share. And again, we don't share the names or identifying things about the families that we serve through this pathway. But it's important to really explain that so they feel that they can trust us and not worry that we're part of CPS. All right, so some of our Navigator considerations, these are the folks that are constantly working hard to improve and support the families that they serve. And these are the folks that would reach out to the families that get referred to us through the plan of safe care. They're constantly engaging in trainings and professional development to stay informed. They're thoughtful in making sure their engagement is trauma informed or healing centered. And they've worked on learning motivational interviewing as a concept at the core of their model. And since they provide flexible but limited time support, they're intentional about connecting clients to longer term support, such as home visiting and place-based supports in their community, such as family resource centers. And they work to maintain relationships and stay up to date on the other programs available for states or available in the state for families. And they are both moms. Both of the navigators are both moms. And we find that peer kind of navigation is a really great approach and is best practice, which requires organizational readiness and the infrastructure to support. All right. And so throughout this work, we've also recognized that it's vital to include tribal populations and the communities throughout Washington in the building and sustaining of this work. So we're excited to be in the learning and relationship building phase and are still very early in our work alongside our tribal partners for this plan of safe care work. Some examples of what we're doing are identifying resources that could support non-tribal members who come into the care of tribes. There are a lot of different, examples of that. And then learning more about the unique models of support and community care that already exist in tribal contexts. For example, we recently had a team from the Office of Tribal Relations attend our Plan of Safe Care community of practice and discuss how Plan of Safe Care can look in a tribal context and share more about the Indian Child Welfare Act and the Washington Indian Child Welfare Act. And I think I saw a few of those folks actually in attendance today. So hello, if you're here. All right, next slide. So some next steps that we're considering as we think about growing and sustaining this work, there's several projects and kind of wish list items on the horizon. So some of these include the promotion of a self-referral pathway where people could actually refer themselves to the community-based pathway, Help Me Grow, and expanding the plan of safe care, referral pathways beyond birthing hospitals. So we often get questions about pediatricians being able to make referrals and kind of other providers and entities. So exploring that, and then exploring options with the department for screen outs and cases closing. So when a family no longer needs CPS intervention or child welfare intervention, how can they kind of have that bridge to support through Help Me Grow? And then also expanding our pregnancy support pathways statewide hub, which is a pilot project to get pregnant people using substances connected to support before baby's born. And that, again, is more of that prevention model, and it's not part of the Plan of Safe Care legislation, but we found it to be really impactful to actually reach families before baby is here. And then lastly, exploring our Family First Prevention Services Act, FFPSA, as a potential funding mechanism for this work. All right, next slide. I think I'm right on time, but if you have, I know we'll have Q&A time later, but if you have any other questions, feel free to reach out to us. We would love to continue this conversation.
Thank you, Kate and Maria. Perfect timing. That was great. We will indeed have time for people to ask you guys questions and put their questions either in the Q&A or in the chat so that we can get to those when we are done with our formal presentations. So now we're going to move on and bring you the team from Colorado. And that's going to be Alicia and Kelly.
Thank you, Dr. Tate.
Hi.
Hi, my name is Alicia Chang, and I am the CAPTA Federal Funding Administrator from Colorado's Division of Child Welfare. And Kelly and I are here today to talk about the implementation of plans of safe care in Colorado. Next slide, please. So today I want to cover where we've been. I'll go over a history of Colorado's plans of safe care implementation. I'll talk a little bit about our lessons learned, and then I'll turn it over to Kelly to tell us where we are right now with our plan of safe care pilot, and then I will wrap it up with where we are going. So as you've heard at the beginning of today's presentation, plans of safe care was first introduced at the federal level through CAPTA in 2003, with significant revisions over time that reflected our growing understanding of substance abuse and recovery, its impact on families, and best practices for working with families impacted by substance misuse and abuse. The plan of safe care requirements at CAPTA are pretty broad, which allows for states to tailor their approach to their individual needs, capacities, and systems. Next slide, please. So this slide shows some of the work that Colorado has completed since plans of safe care was first introduced in CAPTA to not just implement plans of safe care, but also to improve how our state systems support infants and families impacted by substance abuse. We have seen that plans of safe care is really just one tool that should be used in a comprehensive approach to support families. To be most effective, state structures, statutes, legislation, policies, and procedures also need to be revised to reflect current understanding and best practices. We have also seen that implementation of plans of safe care is something that has needed to be gradual and perhaps will always be evolving. This comprehensive approach has only been possible through the collaborative cross-system partnerships that we have. This slide shows just some of the plan of safe care projects in Colorado that are happening across the perinatal period. To help coordinate all of these efforts, CDHS has contracted with a state nonprofit, Illuminate Colorado, to facilitate a multidisciplinary group known as Support Colorado. This group includes a family advisory board and participants from hospitals, state and local child welfare departments, the Colorado Behavioral Health Administration, the Colorado Department of Public Health and Environment, private and nonprofit agencies, as well as our county partners. So we've had a lot of successes over the years, some of which are highlighted here, but due to time, I won't go into all of them, but I do want to take a moment to briefly highlight two. So the first thing is perhaps the most significant change. It was in our state definition of abuse and neglect related to infants identified as prenatally exposed to substances. Since 2020, prenatal substance exposure does not automatically equate to maltreatment. Prenatal substance exposure only meets criteria for abuse and neglect when a child is born affected by alcohol or substance exposure, except when taken as prescribed or recommended and monitored by a licensed healthcare provider, and the newborn's health or welfare is threatened by substance use. Another key success has been the leadership and involvement of individuals with lived experience. These folks have been active in our work groups, developing and providing training to healthcare providers, contributing to the development of our statewide templates and tools, and increasing family engagement in the development and use of plans of safe care in our communities. Through our work, we've identified that not every infant or family eligible to receive a plan of safe care under CAPTA legislation is actually receiving one. This is in part because plans of safe care is embedded in federal child welfare legislation. And in Colorado, only child welfare professionals are legally required to develop and monitor a plan of safe care with a family. But not all infants born with evidence of in utero substance exposure require the support or involvement of child welfare services. Next slide. We've also identified some key challenges to implementing plans of safe care in Colorado. While we know that plans of safe care can be incredibly effective in the prenatal period, in Colorado, child welfare cannot engage with a family prior to the birth of a child. As a result, no one entity is responsible for the development or monitoring of prenatal plans of safe care, so prenatal efforts are inconsistent across the state. Colorado has not had a clear and distinct notification versus reporting policy or procedure for healthcare providers either. This has impacted the data collection that is necessary for federal reporting, but more importantly, has also reduced provider and patient engagement in plans of safe care. Also, because we don't have a plan of safe care protocol outside of child welfare, we're currently unable to ensure and track the development of plans of safe care or referrals to appropriate services for families not involved in child welfare. We recognize that in order to make plans of safe care effective, cross-system coordination is essential. However, that same cross-system coordination can be difficult at both state and county levels. Barriers are associated with navigating data sharing and confidentiality requirements, historically tense relationships between systems and agencies, constrained resources, and limited capacity. Colorado also has a state supervised and county administered child welfare system, which means that county child welfare offices have more autonomy to make operational decisions regarding state and federal policy implementation. So this can really result in quite a bit of variability between county practices. From all of this, there has been some key lessons that we've learned. Plans of safe care can be a wonderful tool for planning for the safety and well-being of maternal infant dyads impacted by prenatal substance use at any point across the prenatal continuum and should be offered as soon as a potential need is identified, especially prenatally as possible. To have the biggest impact, plans of safe care should not just be a tool used in the child welfare system. Multiple entry points are needed for developing a plan of safe care to achieve the goal of early initiation or prenatal initiation and reduce child welfare involvement. Cross-system collaborative ownership of the plan of safe care is necessary to ensure care coordination is held as a shared responsibility across sectors and supports as well as to meaningfully engage families. To address identified barriers, plans of safe care implementation requires state-level policy and investment in an approach that can be tailored to county or regional specific needs and strengths. Lastly, it is important for us to develop a separate notification and reporting system. These learnings have informed current Colorado initiatives and pilots, one of which Kelly will now dive into. And Kelly, I'll turn it over to you.
Great. Thank you so much, Alicia. And thank you for having me. And I am here to talk about our Plan of Safe Care pilot in Colorado. Next slide, please. State Department of Child Welfare is funding the opportunity to pilot the implementation of a Plan of Safe Care framework in a community. The Colorado Evaluation and Action Lab is the lead on the pilot, and partners include Illuminate Colorado, a statewide nonprofit strengthening families organization, and the Kemp Center for the Prevention and Treatment of Child Abuse and Neglect. The Plan of Safe Care framework emphasizes prenatal plan of safe care for an upstream approach to improve outcomes. The pilot team intentionally developed a framework for implementation instead of a program or model, and we did that in order to plan for capacity building within a community and for future scalability if the findings are favorable for this approach. Next slide, please. A catchment area was identified, and this was chosen based on need and readiness. The San Luis Valley in Colorado has been doing work to improve outcomes for families impacted by perinatal substance use through a local neonatal task force for many years, and also has the support of a HRSA neonatal abstinence grant. The official kickoff for the pilot was July 2024. Next slide, please. And we also ended up having an opportunity to expand the pilot into another area. And we are currently in the planning for that expansion. So the pilot team agreed that expanding to another area could accelerate learnings within that area that also has the readiness and community support, especially because they also have a safe babies court. Next slide, please. So the Plan of Safe Care framework was developed, tested, and refined through this pilot, and it consists of these interconnected components. So initiating, developing, and coordinating a Plan of Safe Care is designed to occur across multiple entry points, ensuring that there's no wrong door for a family to have an opportunity to develop a plan of safe care and have an opportunity to engage in ongoing care coordination. Next slide, please. So how are we accelerating progress in this space? Plan of Safe Cares are voluntary and family-led. Having the multiple entry points outside of the birth hospital can equip the community to, again, kind of meet that capacity need. And then our entry points are all equipped to make a referral to what we're calling a specialized provider who can actually provide the ongoing care coordination, the development of that plan of safe care, and then seeing that plan of safe care continue. So entry points have been identified as folks in the community where substance use is not necessarily within their scope, but they are interfacing with pregnant people who may be impacted by substance use who could benefit from a plan of safe care. So they are equipped to identify that, initiate the plan of safe care, and set that family up with a specialized provider that can develop that ongoing plan of safe care and that care coordination plan. Next slide, please. So how did we go about doing this for the pilot? We started off with a town hall, and we invited the community members, invited all the family serving organizations to come together and identify themselves as, we are an entry point for a plan of safe care. We are interfacing with pregnant people who could benefit from a plan of safe care, or we're a specialized provider. It's within our scope to be doing care coordination. We already kind of have an infrastructure for that, and this would just enhance those already existing infrastructures. So after that town hall, where we were able to really identify who are those folks in the community that will kind of share this responsibility for supporting families through plans of safe care, and we co-developed the workflows for each of the organizations, which included co-development of a workflow for families who do enter the child welfare system. So if a family enters the system, our hope is that they will enter the child welfare system with a plan of safe care that can then inform the child welfare plan of safe care and hopefully come into that system at a lower acuity because they have been set up with those resources. And then we held our kickoff meeting. Next slide, please. So this is just a slide to say who is at the table, who are the partners that we're working with. And as I mentioned, local Department of Human Services, Child Welfare Division, the Birthing Hospital, other community organizations, and just want to highlight here the importance of having our lived experience experts at the table. So peer coaches, case advocates, recovery doulas have been at the table since the beginning of the pilot and are continuing to help support the pilot. Next slide, please. And then here you can kind of see a visual of our activation pathways. So what does that mean when an entry point makes a referral to a specialized provider? And then through those workflows, we've kind of developed what this can look like ongoing in the community. But what we've really noticed is the secret sauce is those strong relationships. So building those relationships between entry points and our specialized providers and our local Department of Human Services has really been key in activating these pathways. So we know that addressing the many needs of children and families affected by perinatal substance use requires a data-informed, family-centered approach across the multiple systems. So this pilot is really offering that opportunity to create a shared understanding of how do we best support through plans of safe care and ensuring that communities can really meet the unique needs of families. And together we can cultivate a culture of collaborative responsibility for ensuring that Colorado families have the opportunity to thrive. Next slide, please. We do have some early key learnings from the pilot, and this first one just kind of talks about pilot engagement. So the engagement of our organizations, our lived experience experts. Again, those existing relationships and that infrastructure that already existed is really what we have been enhancing. And then also creating this surround sound around the pilot and plans of safe care and reminding our entry points and specialized providers and community members and families how they can engage. There, of course, have been some barriers that we have worked through. There have been some historically complex and some strained system relationships that we really had to kind of work through in order to really have that shared understanding and that shared commitment. Staff turnover has been difficult. So again, kind of creating that surround sound and multiple opportunities to have this conversation has been really important. Using pre-existing spaces and just asking to kind of come into those meetings to talk about plan of safe care has been one of our best ways to reach partners. So we're not adding additional meetings or additional stress kind of on systems, but really coming to them and talking to them about how they can support plans of safe care. Next slide, please. Key learnings on prenatal initiation, relationships, again, are so important, and tools. What we learned from our community is it's really helpful to have one-pagers. So one-pagers for healthcare providers, reminding them of kind of what does it mean for them to be engaged in plan of safe care and kind of what is their shared responsibility here. The community members, what does it mean for them to be engaged in the plan of safe care and understand this opportunity to support families? And then also for families, how could my family benefit from a plan of safe care? This is family-led. family-led. This is your family's plan, and just making sure that that's really stressed in the community. And families are able to refer themselves for a plan of safe care as well through our shared referral platform. So that has also been a success of having a referral platform, which is a QR code that anybody can scan, and that referral will then go to one of our specialized providers, and then they will help with the family kind of decide who will be that ongoing care coordinator. The barriers, because in a rural community, substance exposure during pregnancy is a low frequency event. We still do have to continue to come into the community and talk about this opportunity frequently. Trust building, continuing to do that as we talk about plans of safe care and coming back to the community and sharing some of that data, sharing some of those success stories of families who maybe were diverted from the child welfare system because they had a prenatal plan of safe care. So that is also key, I think, to keeping this going and sustaining. Next slide, please. Key learnings from service referrals. So who are we actually getting referrals from those entry points for a plan of safe care? We are seeing referrals from mental health, behavioral health providers, postpartum depression recovery supports, harm and risk reduction organizations, and the criminal justice system. And then what are families being referred for the most? Transportation, WIC, baby items, some of those hard goods that we know that families need to thrive, and then also infant development knowledge and care. And then what is driving the success in the positive resolutions of those services being made? The warm handoff, I think that that's the biggest thing, is a warm handoff between who's developing the plan of safe care and the provider that will be providing the ongoing services, the responsiveness of those community providers, and that it's a good fit for the family and there's some trust there. And then I would also just highlight here having referrals for peers. In the community, peer coaches, recovery doulas has also been key. And peers do such a lovely job as doing those warm handoffs and really supporting families through that process with that lived experience behind them to really support that. So yes, thank you so much for letting me share a little bit about the pilot and some of those early key learnings, and happy to answer any questions as we go. And I'm going to turn it back to Alicia quickly just to talk about where we're going. Next slide, please.
Kelly. So let's skip over to the next slide. So for CDHS, our primary goal is to safely reduce child welfare involvement and improve outcomes for families who become involved with the child welfare system. And as a state, we're committed to using evidence-based decision-making and policy-making. This includes considering the best available research, examining current family needs and experience, and incorporating learnings from professionals. We plan to assess the trends in our state data to see if current efforts are reducing child welfare involvement and improving outcomes for families. We will then use this information to help guide future investments and policy decisions. And that concludes our presentation. If you have questions, my email, Kelly's email, and then Shannon Bryan, our substance use policy and practice administrator. Her email is also listed on here, so feel free to reach out to any of us.
Thank you, Colorado team. That was great. So now we have some time to have a conversation with each other. You guys both teams shared so much information. And so we're going to have a lot to talk about here. The first thing that I want to ask you, and this is for anybody who wants to pick up on it, is when you were listening to the other presenters, what kind of grabbed your attention and made you say, and resonated with you and made you say, oh yeah, that happened with us too, or oh yeah, that was something that we had to work on or consider, or commonalities and experiences, where I'm going here, for whoever wants to start with that.
I'll kick us off. I heard Kelly mention one of the key components around relationship building, and I think we learned that here in Washington pretty significantly. We went around and we did a lot of trainings with our birthing hospitals, and as you know, in our social services, healthcare sector, people turn over in these positions, and so really trying to maintain good, positive working relationships with our communities. Kate has been fantastic about doing a community of practice where we invite community partners and birthing hospital staff to come and talk about real life like examples and circumstances that they're working through. And so I think that that's been pivotal here in Washington.
Mhm.
Yeah, to go along with that too, I also heard with Washington having folks with lived experience at the table. And I know I highlighted that and you all highlighted that as well, and just how key that has been to have folks with lived experience from the very beginning. And then I would just also echo that cross systems collaboration and continuing to invite people to the table. We have seen being able to kind of see where our referrals are coming in, really seeing some success in engaging what we're considering like the entry points in the community.
Yeah. Absolutely. All right, so we're going to take a little bit deeper dive into, a couple of those things. Let's talk a little bit first about engaging folks with lived experience. Both states have talked about, doing that. Um, how did you begin that process? And what do you feel like it took to be as inclusive of the voices as you might have wanted to be?
I can start us off here. We were extremely fortunate that some of the already existing partners have already hired folks with lived experience as case advocates, recovery coaches. So we were able to kind of talk to them about what could their role potentially be and make sure that that's either in their job description or that we have a way to fund their time to participate in some of these spaces. Because some of our folks with lived experience, it is within their job description. And if it's not within their job description and we would like them to be at the table, just being really mindful about compensating their time for participating in all the different spaces. The other piece that we also kind of tapped into was some statewide organizations that have recovery coaches that are very passionate about supporting folks during that perinatal period, and then making some connections with folks in the community there as well. And then seeing how we could partner a little bit closer, even though they don't live in the community, but they have peer specialists in the community, and how can we better partner and build them into our workflows too.
Oh, that was great. That was a good idea. Yeah, tapping into where those voices are already participating in service. What about you guys?
Yeah, I can talk a little bit about what I've been involved in. And Maria, I don't know if you want to share about the citizen review panels or some of that like work that predates me, because I'm still relatively new at a year and a half in. But on the Help Me Grow side, we've done a lot of these family listening sessions, and again, leveraging our partners that already have those parent ally mentors employed. But we also have, found ways to compensate them because it's an additional ask that we're using for our materials or whatever. And they're and also the parents that have been clients that aren't employed by the partners. We've also invited them to the table to kind of share. So that's been really a great way to hear from families and kind of have these listening sessions, and then also some kind of one-on-one like interviews or more like conversational, just asking them, what would be helpful or what they think about, the messaging and all that. And we've actually taken the learnings and incorporated them into everything from like the image on the flyer that we use to our outreach scripting that we use, how transparent we are with like, so and so referred you, or, being really clear about what we can and can't do to not get people's expectations, raw up or down or whatever. So that's been really impactful. And then also just how we think about reference and realizing that, social workers might not be the best people to introduce this idea to the parents because they might have their guard up, when they think social worker. So exploring some of those other folks in the community that could be maybe a more trusted person to make that referral. Yeah, those are just some examples of what I've been involved in.
Those are great. Those are very good examples. We're always, and I'm going to be always conscious of this as I'm asking you guys, questions in this conversation. We're always wanting to make sure that the our audience comes away with some ideas of how they can go back in wherever they are and attempt to do some of this work. It's a, um, I don't think that it's a one person goes back and starts a whole initiative by themselves. Um, but I always say people can do something from where they sit, and they're going to learn something from you guys today for sure. Um, I want to, so along those lines, Erin, I want to ask you a question from your viewpoint, working with, having interacted with multiple states that are doing this kind of work. How do they get started? Like, how does it start?
Yeah. I was thinking about that when I was listening to you all present, is like the original piece of legislation happened in 2003. The CARA Act changed it in 2016, and that's where we saw a lot of the bubble happen around the work. And it's when you have a policy change, there's here's the policy as you receive it, and then there's the uptake of how do you implement it. And so I'm thinking a lot about like the implementation science pieces that people followed. Like some of the commonalities that I see here and in other states are the engagement of lived experts, the ability to form those relationships. The other piece is like that co-design piece that was touched on by everybody here. There's different leverage points. So like, I don't know, from my privileged position of knowing both of these states somewhat well, a little bit better in Washington because I lived there and worked there for so long, but being able to really dive in and like what are the key ingredients we have to make this the thing that works best for us, and how do we do that? So one of the things I was thinking of is like, Kelly, your the support collaborative, the way that you've structured that, where you have each of the work groups led, like co-led by parent leaders. You have you get to report up to legislators who really care about this work. It gives you a different purview and a different audience for that work. And in Washington, it's a little bit different, still strengths there. But I think the thing for me is like, there are so many right ways to do this that can really put families front and center. It's that piece of taking a policy and then implementing it, and what is the opportunity. And I think we see a similar opportunity with FFPSA across the country right now. Like that's also a similar type of thing of like a federal law was made and then it comes down, and then what are we going to do with it in our state? And then you have all these prevention plans that now are rolling up. So they don't have to be separate things too, is the other piece that I think about. So working as part of the Safe Babies team, I get to see plans of safe care directly relate to what's happening to infants that are in the child welfare system and the trauma responsive supports that those families need and deserve. So being able to look at how do we bring what we know about plan of safe care into something like Safe Babies if you're implementing that in your state, and then how do we talk about and package this so that it's a comprehensive experience for families. And I think that really stands out to me as like a place where Help Me Grow is really helpful, of like Help Me Grow is a universal open door for everybody. Illuminate Colorado has some of those strengths as well, of like when it's a universal open door, it doesn't feel so different. And the last thing I just wanted to emphasize is like we had the chance as 0-3 to do some listening sessions in Washington State and around perinatal substance use and what would get you into services. And I was surprised, like one of the participants had said something about your plan of safe care can be a tool that you use if CPS becomes involved. So that reframing of it as like, this is something I can say, I have been thinking about this. I do care about what's the right services for my families. And that's something that providers can really highlight and join in on as well. I could brag about these guys all day. So
yes, yes, and it's quite warranted. Thank you for that, Erin, for that perspective. I love where you said there's so many right ways to go about this. That's a quotable, and hopefully inspiring to people who are watching, going, well, do I have, in my community, do we have enough of XYZ, to actually get this going? And so if you remember that there's so many right ways to do this, might be a little bit more likely to take some action. So that's really helpful. So I want to talk now about another commonality, which is partnerships. Partnerships between multiple organizations, kinds of organizations, public, private, community-led, state-led, all that whole piece, because none of this happens without partnership, right? And partnerships are challenging to form and challenging to maintain. So, wisdom from you ladies on partnerships. What would you like to say about the partnerships that you have worked to develop?
I'll kick us off. One, I just wanted to quickly note that I did put in the report that Erin had referenced that we had partnered with 0 to 3 on. And it's a lovely report, so I encourage folks to read through that. We have been really fortunate here in Washington to have a strong collaborative partnership with Help Me Grow Washington. I think, and I'll let Kate speak to this a little bit, but I think what we have found is that there is a balance between trying to offer something statewide and having consistency. We're a state-run child welfare system here in Washington, and also trying to balance the need for localized support services and building those relationships as well, because having connection at a local level, I think we can all agree is really impactful for the families and kids that we serve. So that's something that we've been trying to build upon, is building those local relationships as well.
Great. Yes, absolutely. So being statewide and local simultaneously. Who else wants to share something here about partnerships?
Yeah, I would add
Yeah.
just identifying your champions in your communities. I think that that is always key too. And we've done that through listening sessions, town halls, and just some already built relationships. And we've been so lucky to have state DCW so supportive of all of this. And then state DCW in Colorado is really helping their counties kind of understand this. And then we're helping to make those community connections between the county and then their community organizations and their birthing hospital. So we've done a lot of that focusing, and it's a shared kind of thing. Not one organization is trying to like build up these connections, but kind of figuring out where are those intersections and where can we kind of help be the facilitators there. But yeah, we've been lucky to just really identify like where are those champions and how can we kind of turn to them to help us build those relationships up and then bring that information back to their individual organizations.
Yeah. So I'm wondering, as you're speaking about champions, I'm just wondering about this idea of buy-in. Like, when you approach an organization, how do you go about getting buy-in? And how do you go about creating champions? Because somebody can end up being like a great champion for you, but they weren't in the beginning. So, so you kind of have, you're in the business of also getting buy-in and creating champions. And I'm just wondering who wants to share about that.
Yeah, I think starting off with data has always been really successful for us. Like looking at, we have like a data snapshot with publicly available data where you can see like, here are the things that, we're all trying to change within our organizations, and then kind of figuring out where are those points of commonality, where it's like, I think for DHS, a good example is, they may get a referral to their hotline from someone who's pregnant and they don't get involved, right? Like DHS can't get involved when someone's pregnant, but now they have this tool to say, you can actually refer yourself to start a plan of safe care during pregnancy. And I think our DHS partners were like, oh, amazing. Like we want families to get that support upstream, and get that help and support early. And now we have this great mechanism to do that. And I think same for our criminal justice partners, like a probation officer who may be working with a pregnant person impacted by substance use. Now they have this tool to get some extra support. So they're not trying to do all the referrals themselves and keep track of all of that. Nope, we've got people in your community that are here and ready to do that ongoing care coordination. And then you guys just, can communicate how that's going at the family's kind of discretion. So I think, yeah, starting off with the data, we all have a shared kind of wanting to improve this data, and then talking about here are the mechanisms. And then I also think it's so important when you have successful data and success stories, then to go back and share that. Like, look how this worked when you sent this referral. this family got what they needed and they didn't end up in child welfare, you know, or they did and they had a plan of safe care already. So maybe baby wasn't removed. And so, yeah, I think being able to share those helps with that shared commitment.
Great advice. Great advice. Absolutely. Um, Data speaks, you know, so it's so important. It's also like one of the areas that can be very challenging, you know, when you're starting up, getting going, is like, where do you get your data from, and who's, I don't know, Erin, are you, maybe you have some thoughts about how states overall address this issue of data collection and reporting.
Yes, I would put Washington on the spot for that because that's the one I always
Okay.
go to. They have a prevention dashboard that's on their website that is pretty fantastic and makes community data available. I know there's some really great data resources in Colorado. Georgia also has Georgia's a fascinating state because they have 159 counties. Coming from Washington State, we have 39. And it's a similar landmass as Arizona, which has 15. So it's like 159 counties, and how do they disaggregate their data and then look at it and examine those different components. But I was hoping Maria would put that in the chat as we went, because the dashboard is really helpful. I think the other thing people think is you have to get ahead of the mental model around what it means to be involved in child welfare services. And I think the dashboard from Washington State really illustrates that, of like, so many people see the newspaper reports that are awful, horrendous, you know, examples of child death and child fatality. And so their mind makes that leap, that heuristic leap into like, oh, this is everybody who goes into child welfare. And really it's, in Washington, by and large, it's neglect. And we see that across the country, in so many states. So how do you do that? Nobody intends to neglect their child. Sometimes it's a condition of poverty, most often. So how do we address things like poverty together and get ahead of some of these situations that could lead to neglect? And really exploring, how do we do this together? I want to pause, but I also have a question for the panel, just because I was thinking about, like, as we were preparing for this, like the trajectory when plans of safe care started, like the most common drug was methamphetamines. So when that policy was developed, it was for a different context. And then now we know, fentanyl, opiates are a driving factor. And I was very curious about how that shifted your partnerships or your approaches over time, and if you had any pieces about that. But if people have other things they want to share about data, I just find data is a really good universal bipartisan way of approaching an issue that can really create alignment, because it gives people almost that shared third point. So a question and a response all in one.
Thank you. Thank you. I don't know if anybody wanted to say anything in response to Erin right then. Maria.
I'll just share, I did post the link to our prevention dashboard, which is somewhat new for us in Washington, and a really valuable resource for community partners. Think school officials, school districts at the local level. They can see information about our child welfare system in a way that they have never been able to do so before. I think primarily the way that we can look at this data is through a targeted response. We all know this. There is a question in our Q&A about, funding streams, and in Washington State right now, we're facing some budget shortfalls in our legislative session. And so we are always cognizant of knowing that if we are in a resource deficit space, how can we target our interventions either geographically or through specific populations to try to enhance our prevention efforts in a way that is going to kind of give us the most bang for your buck, for example. And so that's how we've been trying to target some of our focused interventions, especially if we can't do anything in a grand, scale. So.
Yeah.
Okay, thank you. Oh, go ahead, Kate.
Oh, I just wanted to speak to Aaron's question about the substances that are most common now. Just, I think there's more we could say on the Washington State side and some laws and things like that, but I won't speak to that right now. But we find a lot of questions from the hospitals that we're training about fentanyl specifically, and kind of a pushback like, well, how can fentanyl be safe, or, just these kind of questions. And we're like, well, we're not saying that it is, go through the portal, you answer the questions. And typically if that is indicated, it's going to suggest, the CPS pathway. And often it's fentanyl and methamphetamine that they're seeing. But there's a drop down list of different substances that someone could indicate. So we aren't usually at Help Me Grow assisting families that are dealing with a fentanyl issue. But yeah, it's usually a question that does come up because there's such a strong response, because the fatalities and the impact has shifted. So yeah, I just wanted to add that from my experience.
Well, I'm glad that you did, because we had a question earlier. I can't remember if it was in the chat or the Q&A, but I wanted to kind of get into the weeds with you guys a little bit around this, the way you developed your decision-making tool or process or algorithm, between whether or not a particular family goes to the CPS route or they go to the alternative community pathway, Help Me Grow in Washington, or pathways that you guys are creating in Colorado. Can you talk a little bit about that decision making and how you developed your process, your tool? Colorado, how'd you guys do it?
Yeah, so I think it's kind of a twofold answer to this, right? Because I think, as I shared earlier in the timeline, we've changed our definition of what constitutes abuse and neglect as it relates to substance abuse. I'll actually put something in the chat for you all too. There's a lot of resources on this site that tells you a lot about the legislative changes that we've made in the state. And let me just actually share it with everybody and not just share it with one person. But that FAQ kind of has a whole lot of drop down options for, our most commonly asked questions. But the one I really want to draw attention to is when we changed our definition of abuse and neglect for substance exposed newborns, we removed kind of the reference to Schedule 1 or Schedule 2's controlled substances. And we've kind of made it more broad to really say, it does constitute child abuse and neglect when a child is born affected by and threatened by substance use. So it's kind of that change in definition that I also want to speak to, kind of, Aaron, your earlier question of we also need to be responsive to the needs of the communities and the state on a gradual basis. It's continuously making these changes, reflecting back to the timeline that we have. It's constantly shifting as we learn more and more. In regards to the notification portal, there is kind of a decision tree process in the algorithm to really separate out when we do actually see kind of the answers starting to meet that definition of abuse and neglect. That's when it will flag you to say, stop right now, like make a call, make a referral, finish the portal, but this is at the point in which you need to make that referral. So it's kind of a two-parter for us. I think it's just really important for us to recognize that, as we looked at changing the definition, there are kind of other considerations that we've been making throughout the process in order to reflect that.
Mm-hmm. Yes, we have a question that's going to take us a little bit more into this. So we have a question from Christina here that says, do you see any differences in reporting for just marijuana use, or any pushback or buy-in issues from families who only use marijuana, whether illegal or prescribed? We are seeing a huge influx of POSC reports being only marijuana use. We got a response on that?
I can speak to that a little bit. For the Help Me Grow community-based pathway, a lot of the folks that are routed to us are for things like marijuana, and sometimes in conjunction with alcohol or something, but oftentimes marijuana. And in Washington, it's a legal substance, and so, but still kind of explaining to people that it's still included in that threshold for what would constitute needing a plan of safe care. And again, because it's legal and if there's no safety concerns, usually they're being sent to us. But that's a really good question because it's quite, widespread here. So I think some people might not consider themselves as having a substance use, disorder. So that might be a little bit strange to them to be offered this. And in that case, they could decline, at that point. They don't need to say yes to a referral to Help Me Grow. But oftentimes, they'll still accept and see what kind of resources they could get, because I think, in general, there are things that could still be beneficial for people, even if they're, just using marijuana, they might still benefit from having some of those wraparound supports and services. So again, and it's about the resource navigators not making those people feel stigmatized or say you have a substance use disorder, but really just being like, how can I meet this person where they're at? And if they don't need my support, then that's great. They have their own support system. Great. But if there is anything they can offer, then that's also great.
Wonderful. Thank you for that. Thank you for the question, the person who asked it, and thank you for that answer. So that leads to a question about that we had in the Q&A about connectivity, and what they were asking about really is making connections with other kinds of programs in Washington with your ESIT. Maybe you could tell people what that is, with home visiting programs, with other kinds of programs that maybe wrap around. They may just be ECE programs. They might be concrete resource programs, but if you guys could talk a little bit about how you connect with those other programs to make the warm handoff that you talk about to families, and what kinds of programs that you refer to.
Yeah, I'm happy to speak to that on our end. Maria, would you want to start on the DCYFN, or I'm aware I've been talking a lot. Is that okay if I share? Okay.
Yep.
So yeah, on the Plan of Safe Care Help Me Grow side, we frequently refer families to ESIT, or oh my gosh, now I'm blanking on what that stands for. Can someone help me
Early
out?
support
Early
for
support
infants
for
and
infant and toddlers. Thank you. Okay. Yeah, so we often refer for that. And I believe that in Washington, substance exposure prenatally is like an automatic qualifier for getting that screening, that service. So we always kind of recommend that to families. And then in the hospitals, we also say it's okay if you want to refer to ESIT as well as the Plan of Safe Care. You can double dip, whatever can get that family that service quickly as possible. But we'll actually walk through it and explain with families. And then the home visiting, a lot of times our navigators know kind of all the different models of home visiting that is available. There's lots of different ones, and they'll kind of talk through that with the family, see what's the best fit, what's available in their community. And then instead of just saying, here's a list, you can call them, here's their hours, they're open, which may or may not be, up to date and accurate. A lot of times our resource navigators will actually call with the family and kind of do that really warm handoff, or wait on hold before the family needs to, and then say, okay, I was able to get a hold of this program, and here's, the wait time, and here's what they have available, and they'll relay that to the family and then bring them in. So really trying to take some of that burden of the waiting and looking through, finding what's actually available. That's been really an asset of the program, and the families are, I think, really happy with that part of it.
Yeah, that's so important. That's so important because it's so hard for families to do it without that kind of help, right? Colorado, what are your thoughts on this topic?
Yeah, I would say that we, for the pilot specifically, did like a landscape of all of the like family servicing like organizations, all the children's supports, early intervention, substance use supports, and kind of just did a full landscape and identified like who were kind of our partners at those spaces. So then we are able to kind of make those same thing, the warm handoffs, just really making sure that we know that those organizations are involved, open, have openings, and really just understanding the community a little bit better. And some of the behavioral health organizations have like the nurse family partnership embedded, safe care embedded. and other home visiting programs embedded. So then that was a really easy way for us to kind of continue those connections with those supports for both the birthing person and baby. So yeah, I think just kind of doing that larger landscape. And then there's a statewide campaign, the Tough as a Mother campaign. And part of their campaign is stigma reduction. And part of the campaign is connecting folks to resources. And service providers can get on their list and stay up to date through our 211. So then folks aren't getting kind of just a list of referrals and having to call to figure out if they're still open or still providing that service, but they really keep that up to date and do some like social media pushes of those services for families. And it's really specific for families impacted by substance use. So another statewide organization that's really helping in all communities.
That's great. That's good. I love the landscape idea. So other states can pick up on it. Just wanted to let Washington know that, to let Colorado know that Wyoming is wanting to partner with you. So they're saying right here in the chat. So around children that are born in your state. I'm going to get to a funding question, but before that, I just want one more in the weeds question about making those decisions on those two pathways and what happens if a family declines. This is all voluntary, right? And so what happens if a family declines? Is there a follow-up or a tracking response, or the question here is it documented, or just like what happens?
I can speak to our pilot. So for our pilot, we are collecting that information to learn from it and better understand. And yes, a family can decline the plan of safe care. And that doesn't mean that the family's not going to get kind of, business as usual services. And so I think families are still offered those connections and that care coordination. But if the family is not quite, bought into kind of having this plan of safe care and ongoing care coordination, that is okay. I think there's also a reminder to our community partners to continue to offer along the way. So maybe family wasn't ready at 12 weeks pregnant, but at 34 weeks, like thinking, oh, yep, I think I'm ready for this, or wasn't ready prenatally, then our care coordinators at the hospital are ready to start a plan of safe care. So I think we're always thinking about multiple offerings of this ongoing care coordination and really through the plan of safe care.
Great, that's good. That's good. So it's not a, take it today or you never get another chance kind of thing.
Yeah, and that's the other benefit of our referral system. So a family can actually refer themselves too. So we can give the QR code to a family who's like, I'm not sure about this yet. We can say, that's totally fine. When you're ready, you can refer yourself, and that will go to one of us, and then you will promptly receive support when you're ready for that.
Yeah, that's great.
And Dr. Tate, I put a example of Massachusetts as well. I think those options that let you make your own plan or give you the information of you can self-refer, that puts that control back to the families of reopening that universal pathway door of like, this is something we want to make available because we want to be on your team and support you. And I think if I saw Morgan put her contact information in here from Help Me Grow. That's something like that Help Me Grow can help do in partnership, is help build out those pathways. But really keeping those as wide of the net you can open, the more accepting is kind of the thing that keeps showing up over and over across the country.
Yeah, that's really important to empower the families to make their own decisions about their lives. So love to hear that. Last question about funding and FFPSA, Family First Prevention Services Act funding, and how you use that. I don't know if either of you are actively using that kind of funding right now, and if so, how do you use it?
I wish we were. In Washington, we are not actively drawing down Title IV-E prevention dollars. So right now we're really focused on the infrastructure pieces. So our community-based Plan of Safe Care is one community pathway under our Family First State Plan. I did put a link to our current state plan that we submitted late last year that has still not been approved or reviewed by the Children's Bureau. I think during all of the transitions that I'm sure other jurisdictions are seeing delays. And so that is there. But things like training our navigators for our community pathway in motivational interviewing is one way that we are trying to build the infrastructure to be able to pull down even on some of those like case planning components that isn't necessarily an evidence-based practice, but we're trying to anchor in really positive practice supports. We're also exploring a data management feasibility study for community partners to explore what that is. Here in Washington, we've been pretty limited with our current SACWIS system. And so being able to report on the necessary data elements under Family First has been really inhibited by our data management system.
You're on mute.
I was on mute. Oh boy. Anyone else want to respond in terms of funding before we wrap it up? Okay. Okay. So lots of information. You guys have just been great. We appreciate all your answers to the questions from the Q&A in the chat. And it's been a great conversation. At this point, I always like to put every single person on the spot, although I did give you warning, that I'm going to ask you for a final thought. So I don't know who wants to start, but a final thought for our audience today.
I can kick us off. I think that a final thought I would leave with everybody would be these are two really good examples of taking a policy or a change and then doing something inspiring with it to really focus on child well-being. And gratitude to you all for presenting today, but also we can do that with any policy that comes through. I think we have that capacity to really design things in a positive, family-focused, well-being focused way. And we can all do this better together.
Mm-hmm. It's a great thought, Erin.
Go ahead, Phyllis.
I was just gonna say, I think it's been really, really fascinating to hear about the different approaches that we all have, and then also just really remaining committed to the cross-systems, multi-level approach that we have to supporting our families who are impacted by perinatal substance use. I think it's really important just to really emphasize that cross-system collaboration across all levels.
Mm-hmm. Mm-hmm.
I would just
Thank
add utilizing, working with people with lived experience and continuing to reduce stigma around this is still something that is so important for success. So I think, yeah, any opportunity we can get to reduce stigma and utilize stories of those with lived experience is really impactful.
Yes. Thank you, Kelly.
Yeah.
Tate, go ahead.
Okay. My timing's off today. For me, I think what Erin said in the beginning of kind of there's not a right way to do this or one way to do this. There's different ways to build this out, and I think that's so true. And it's just exciting to have the opportunity to build something that works in our state, in our communities that might be different, and just the opportunity to try things. So it's encouraging to learn more.
Thank you.
I echo everyone's sentiments. What I would say is that in this time of uncertainty and constant change, we collectively, all 193 participants, are really making an impact for families by moving upstream and supporting this population. And it is inspiring to be with you all.
Well, thanks to each and every one of you. It's been really informative and, yes, Maria, inspiring. We appreciate you so much. We appreciate our audience too, and all of you who tuned in. Thank you so much. Thanks to those of you who put questions in the Q&A and the chat so that we could keep this thing rolling. And we want to encourage you again to fill out the survey form that's going to pop up at the end of this. We are on time to end. So thank you, everybody.